Hey, I'm Kelsey Ramsey. I am currently a senior nursing student at UNCG in my final 440 clinical at WakeMed Hospital in Raleigh, North Carolina. I have been working alongside my preceptor for this clinical in the neuro ICU. For this case study, I had the opportunity to work with a particular patient who is a good representation of a common patient admitted to the neurointensive care unit. For privacy purposes, I will refer to the patient as Miss G. Miss G is a 74-year-old Caucasian female who presented to the emergency department at WakeMed via EMS on March 26, 2013 at 14:30. I helped care for Miss G on March 26 and March 27th. Miss G presented to the ED as a code stroke with slurred speech and a right hemiparesis or right-sided weakness. Per the ED report, Miss G's daughter and son-in-law, who Miss G had been living with for the past year after retiring from Florida, arrived to the ED not far behind the EMS. The patient's daughter reported Miss G had been having slurred speech since 11:45 that morning. Miss G's daughter stated she arrived at her house at 10:30 after picking up some soup for Miss G as she had been sick in bed for the past 2 days with cough, chills, and a sore throat. Per the patient's daughter, 1 hour after giving Miss G her soup in bed, the daughter and her husband heard a loud noise in Miss G's bedroom, where they reportedly found her on all fours in the floor, having appeared to have fallen out of bed while attempting to walk to the bathroom. Miss G's daughter reported it was at this time when she noticed Miss G's marked slurred speech, and her husband immediately called 911. The patient's daughter also reported noticing Miss G had bowel and bladder incontinence while on the floor that was not normal for her, and that Miss G was unable to move her right arm and her right leg. Miss G has no known drug or food allergies, and she is a full code. Miss G has a medical history of coronary artery disease, peripheral vascular disease, GERD, diabetes, hypertension, a previous MI status post-CABG 13 years ago, a renal stent in 2011, and a recent bilateral lower extremity arterial bypass just last month. Per the ED report, Miss G had no obvious injury from the fall, and at this time Miss G was unable to provide further history due to her dysarthria or inability to speak, but she was able to say her name and follow commands. Miss G denied any pain at this time, although she was noted as being mildly agitated. Per EMS, Miss G's blood glucose was in the 220s, and blood pressure was also noted to be elevated, with a reading of 190 over 100. The patient's heart rate was 61, respiratory rate 25, O2 saturation of 93 on 2 liters nasal cannula, temperature 98.8. In the ED, at 14:55, Miss G was given labetalol 10 mg IV push over 2 minutes for her presenting hypertension. An additional order of labetalol 10 mg IV push was administered again after Miss G's blood pressure had not decreased after 15 minutes. At 1500, Miss G was given 2 mg Ativan in her left AC IV for her agitation. Miss G was also ordered and started on 100 milliliters of normal saline at 75 milliliters per hour, also at 1500. The ED nursing assessment was as follows. Neurologically, the patient opens eyes spontaneously and has incomprehensive words. Patient attempts to follow commands and can move her right leg sporadically. Pupils were equal, round, and brisk. Respiratory, patient appeared to have no pulmonary distress with a respiratory rate of 18. Breath sounds were clear bilaterally. Cardiovascular, patient denies chest pain. The EKG showed normal sinus rhythm with PVCs, and her pulses were normal in all 4 extremities. Gastro, abdomen is soft, no abdominal tenderness noticed, and bowel sounds were normal and present. The patient has a Foley catheter in place, which was inserted upon arrival to the ED. The patient's skin is pale, warm, and intact. Her skin is wet due to diaphoresis, and her capillary refill is 2 to 3 seconds. The patient is extremely agitated and restless in bed. 2 nurses remained at the bedside in the ED as Miss G pulled out her IV during her agitated state. A new IV was inserted at this time. At 15:20, Miss G's normal saline IV infusion was complete and her IV saline was locked. Miss G still presented as being very agitated, so she received 1 more 10 mg dose of Ativan. At this time, Miss G's labs were as follows. Sodium 134 was slightly low, potassium 4.0, which is normal, chloride 104, which is normal, a BUN of 28, which was slightly elevated, creatinine 1.48, which was elevated, both reflecting kidney dysfunction, probably due to her diabetes that may not be properly controlled at home. Her blood glucose was 226, which is elevated. At 15:38, after the head CT was negative and her NIHSS was 18, she was determined to have an ischemic stroke, which was not hemorrhagic. Miss G did not meet any exclusion criteria for TPA once her pressure was controlled at 134/80, and platelets and INR were noted to be normal. The only anticoagulant medication she had been taking at home was an 81 mg baby aspirin, once a day, so she was still eligible for TPA as she was not on any other medications that would increase her risk for bleeding. Because her stroke was not hemorrhagic, and she was 2 hours status post-onset of dense hemiplegia consistent with a stroke, 0.9 mg per kilogram of alteplase, Activase, or TPA was initiated IV. Following completion of a 10% bolus of 0.9 mg per kilogram, the remainder of the dose was given via infusion over 60 minutes. Prior to TPA, Miss G's NIHSS, or National Institute of Health Stroke Scale score, of which I became familiar with during the care of this patient, was an 18, which indicates a moderate to severe stroke. I learned that TPA is tissue plasminogen activator, a thrombolytic agent often referred to as a clot buster. If TPA is given within 3 hours of an ischemic stroke, it works quickly to dissolve the clot in the brain that caused the stroke and restores blood flow to the brain tissue. TPA cannot be administered to a patient that has had a hemorrhagic stroke, as this type of stroke is due to bleeding from a blood vessel in the brain, and TPA could increase the amount of blood in the brain and possibly cause more damage. A CT scan or an MRI of the head must be done prior to TPA administration to confirm no bleeding has occurred in the brain and the stroke is indeed ischemic, as it was in Miss G's case. At 16:45, after receiving TPA, Miss G was admitted to the neurocritical care unit as a post-stroke patient in critical condition, with a medical diagnosis of a cerebral arterial occlusion with infarct. Miss G's assessment upon arrival to the neuro ICU was as follows: vital signs, temperature 98.7, heart rate 88, respiratory rate 30, blood pressure 182/100, pulse ox 96% on 4 liters nasal cannula. As far as her pain, she was unable to assess, although extremely agitated and restless. Her level of consciousness: Miss G was not following commands, had no purposeful movements, but was spontaneously moving all of her extremities except for her right arm. She was very agitated and restless. Miss G has incomprehensible speech or dysarthria. Her pupils were about a size 3, were equal, round, and brisk, with reaction to light, although she had a gaze preference to the left. Post-TPA, Miss G's NIHSS score was still an 18. Orders at this time were TPA protocol, which included every 15-minute vital and neuro checks for 2 hours. Then every 30-minute neuro checks and vital checks for 6 hours post-TPA, and finally every 1-hour checks for 16 hours. A repeat CT would be scheduled for 24 hours post-TPA to assess condition and make sure no bleeding has occurred due to the TPA. The medications that were ordered at this time are as follows: famotidine or Pepsid 20 mg in 2 ml per IV. This was to prevent stomach ulcers that can be caused in the hospital from stress. Lasix 20 mg in 2 ml IV to prevent fluid overload and help decrease pulmonary edema and help ease Miss G's respirations. Haldol 5 mg in 1 ml IV. This was for her agitation and restlessness. Humalog regular insulin, dosed with a sensitivity of 20 for blood glucose control. Sodium chloride 0.9% with cardine 50 mg for a goal of keeping her MAP between 130 and 90. Ipratropium or Atrovent 0.5 mg in 2 ml inhalation every 6 hours. This for ease of her respirations. Miss G's acid-base balance on 326 were pH 7.42, which is normal, PCO2 of 36.7, which is normal, a PO2 of 101, which was slightly high, as the normal is 80 to 100. This is most likely due to the increase in her oxygen while trying to keep her body oxygenated. Her bicarb was 23.8.